Uh, okay. Good morning. We'll be having our session and seminar on discussing carcinoma stomach. With me today will be Dr. Shomen Das, who was associate professor of surgery at Rampurat Government Medical College, and now he is the chief of surgical division at Netaji Subhash Cancer Institute in Kolkata. So Dr. Shomen Das will be with me, and he will moderate the session. Okay. So we start with the first presentation. Etiology and staging of carcinoma stomach by Dr. Shumon Pal. It will also include the etiopathology. Yes, Dr. Shumon, please start.
Respected teachers and my dear colleagues, a very good morning today. My topic of discussion is carcinoma stomach. My domain will be within the etiology and the staging. Stomach. It is the organ which is the widest part of the alimentary tract lying between the esophagus and the duodenum. Coming first to the basic anatomy and basic introduction towards the organ. It's consists of fundus, body, antrum, and the pylorus. If we go deep into the histopathology of the stomach, we will find that it is consisting of mucosa, submucosa, muscularis externa, serosa itself, which we often found in other parts of the GI tract also. The vascular supply of the, as far as the vascular supply of the stomach is concerned, it gets its supply from celiac trunk by the various arteries, namely left gastric artery, right gastric artery, left gastroepiploic artery, right gastroepiploic artery, and few supplies from short gastric arteries also. The venous drainage, as far as the venous drainage is concerned, it has been found that other various vessels are there corresponding to the artery, and ultimately they drain into the portal vein. As far as the innervation is concerned, parasympathetic and sympathetic, both the supplies are found in the case of stomach. Vagus supplies the parasympathetic division, and the sympathetic is via the greater symplanchnic nerve. Also, there is an enteric nervous system present there, embedded in the wall of the stomach, Meissner's plexus and Orvic's mesenteric plexus, namely. And then comes the important part of the stomach, that is the lymphatic drainage. As far as the CA stomach is concerned, it plays a vital role. It has been divided into various echelons. The first echelon consists of station 1 to 6, where we will find the right and the left pericardial nodes, lesser curvature nodes, gastroepiploic nodes, suprapyloric nodes, and subpyloric nodes. And the second echelon containing various nodes lying around the arteries, namely left gastric arteries, common hepatic arteries, celiac arteries, and etc. Third echelon, where the station 13 to 16 falls, posterior to pancreatic head, superior mesenteric vessels, middle colic artery, para-aortic lymphatics, all these fall together in that group. Also comes the station 20 to 22 also. These images depict the stations and clearly gives us the idea. Now coming to the disease proper, carcinoma stomach. It was once called the captain of men of death. Worldwide, the gastric CA remains the fifth most common cancer and the leading cause of cancer mortality. Coming to the incidence, as far as the incidence is concerned, it has been found it has a considerable geographical variation. In UK, approximately 15 per 1 lakh per year. In USA, 10 per 1 lakh per year. In Eastern Europe, 40 per 1 lakh, and going rise up to Japan, 70 per 1 lakh per year. And it has also been found that in certain areas of China, it also exceeds the Japan. So what does it mean? It gives us a clear idea that it is an environmental disease itself. As far as the incidence is concerned, it has been found that in the case of more the men are affected than the women, and it increases in incidence as the age increases. It has been found that there is also a relation with the socioeconomic status. Stomach CA occurring in the part of the body or the distal stomach has been found to more in the group of people belonging to the low socioeconomic status. Whereas proximal gastric cancer has been found in those people who belonging to the higher socioeconomic status. Now coming to the etiology, it is multifactorial. Several risk factors are there with different precursor lesions. I will start with the genetic causes. Familial history.
Yeah, yeah, yeah.
In the case familial history along with those people having type A blood groups, also those people belonging to the family where HNPCC, Lee-Froman syndrome, Pew-Jaeger syndrome, familial adenomatous polyposis run in the family, have a tendency to get this disease. Now, going deep into that, why this familial condition occur? It has been found that in some family, E-cadherin gene mutation is there, inactivation of P53 is there, or overexpression of growth factors or BCL2 gene mutations. And it has also been found why the blood group A. It has been researched and it has been found that these people have susceptibility to increased susceptibility to carcinogens. And it has been found the secretion of different mucopolysaccharides in the stomach play a vital role in this group of people to cause this disease itself. Now coming to the acquired part, diet, what we take as a diet per mouth goes to the stomach itself. So diet can play a vital role in the causation of the disease. And it has been found that high salt diet, high nitrate diet, smoked foods, low vitamin A and C sometimes plays a vital role in causation of this disease. Now going deep into it, it has been found that nitrate converting bacteria as a factor in the causation of gastric carcinoma. We have seen that when in low socioeconomic classes where the people are bound to eat decayed foods or get exposed to decayed foods where preservation refrigeration is not available up to the mark, there they consume the bacterially contaminated food where mostly the nitrate condensation in the food is high, and they often get Helicobacter pylori infection. Altogether, this causes intake of nitrates in the dried smoked salted foods that goes into the stomach. By the action of the bacteria, it gets converted into nitrosamines, that is carcinogenic nitrates, and that causes a flow of that starts the disease itself via the pathway, which is often termed as a chorea cycle, chronic inflammatory state. Normal stomach goes into a chronic inflammatory state, which ultimately leads to atrophic gastritis, intestinal metaplasia, and ultimately to neoplasia. This atrophic gastritis itself, sometimes in background, gets uh, uh, gets extra effect by the decreased gastric acidity, prior gastric surgery, atrophic gastritis, all this. Now, not only this, in the acquired factors, sometimes those people working in the coal factories or coal mines, those people working in the rubber factories, those people having previous gastric surgery, radiation exposure, or those people having the infection of EBV. As I have said earlier, Helicobacter pylori infection also plays a role, which have a CAG strain. So all this together forms a acquired background where the CS stomach can occur. Not only this, precursors play also a vital role in the causation of the disease. Adenoma, atrophic gastritis, dysplasia, intestinal metaplasia, and Mentriel's disease, namely. Not only all these causative factors, there are some protective factors. Nature has gifted us raw vegetables, vitamin C containing citrus fruits, antioxidants, selenium, zinc, iron, green tea. All these play a very protective role for the stomach C itself. Now, site of occurrence. The disease, it has been found, it has different site of occurrence in developed world and in developing countries. In developed world, it has been found that most commonly 60% cases, gastroesophageal junction and cardia is the most common site. Whereas in developing countries, the pylorus and the antrum is the most common site. Now, coming to the classification of the stomach. Depending on the depth of invasion, depending on the histopathology, various classification has been proposed. I'm starting with Bowman classification and Japanese classification, where it is said that CS stomach can be divided into on the basis of depth of invasion into two groups: early gastric cancer and advanced gastric cancer. In the case of description of early gastric cancer, we can take the help of Japanese classification, where type 1 is considered to be the protruded one, type 2A, type 2B, type 2C are respectively superficially elevated, superficially flat, and superficially depressed one, whereas the excavated one is the type 3. Now coming to the next one, the Bowman classification, where It is basically a classification based on the macroscopic appearance, useful in the endoscopic findings, where polypoid type, that is the protruded type, is considered to be the type 1, and ulcerative as the type 2, infiltrative ulcerative type 3, and diffuse infiltrative as the type 4. Now, the most important classification is the Laurent classification, which is based on the histopathology, whereby intestinal type and diffuse type 2 types are found, which are not defined accordingly, are considered as unclassified, and mostly 14%. That is the most common is the intestinal type, that is 53%. And if we go into the deep of the Laurent classification, we will find that intestinal lesion is a bulky exophytic one with increasing incidence as the age increases, and mostly occur in the males having microsatellite instability, APC gene mutation as a causation, and it has gastric atrophy and the intestinal metaplasia in its background, where environmental factors play a vital role to cause the disease itself. Now, in comparison to this, when we come to the diffuse type, we will find that it is basically a familial type. It goes in the train of familial type, where most commonly the people belonging to the blood group A, and mostly the female gets affected in the younger age group. Basically, it is poorly differentiated, mostly affects transmorally, and spreads via the lymphatics, and decreased E-carrion gene play a vital role in that case. Now, coming to the other classifications, the WHO classification, where we will find adenocarcinoma, adenosquamous cell carcinoma, squamous cell carcinoma, namely all these. And Ming's classification divides the carcinoma stomach into two groups, expanding and infiltrative one, where infiltrative one is the most unfavorable one. Coming to the last classification, broader classification, where differentiation is taken into account, which is mostly defined. The cells are mostly differentiated. It is graded as grade 1, and the last one accordingly it goes, and the last one is considered to be the anaplastic, where differentiation is very poor, which is as a grade 4. Now, genomic profiling of the gastric carcinoma. It has been found those carcinoma occurring in the cardia of the stomach, they the chromosomal these are mostly chromosomally unstable, and histopathologically intestinal histology has been found. The mutation there we found generally TP53. And if we come down from the cardia to body, there we will find in the case of body, both Epstein-Barr virus association is found, along with microsatellite instability is also found. In the last part, that is in the antrum, we will find that mostly diffuse type of histology is found, and basically these are genomically stable, and CDH1 or HOA mutations are found there, and their cell addition is mostly affected. Now, lastly, to the staging, a disease which has this kind of presentation, this kind of introduction, when we go into the management, we need to understand the status of the disease, we need to understand the spread of the disease, and accordingly we chart the management. So we need some tools, and these are TNM classification and Japanese classification in staging. The TNM classification, AJCC 8th edition, according to that, the primary tumor cannot be assessed, is considered to be the TX. No evidence of primary tumor, then we consider it as the T0. When carcinoma in situ, that is intraepithelial tumor without invasion of the lamina propria, high-grade dysplasia, that is considered to be TIS. And T1, which is further divided into T1A and T1B, their tumor invades the lamina propria or the muscularis mucosa in a case of T1A, and T1B, where the tumor invades the submucosa. T2, tumor invades the muscularis propria. T3, the tumor penetrates the subserosal connective tissue without invasion of the visceral peritoneum or the adjacent structure. Now, the question is, what are the adjacent structures? Basically, adjacent to the stomach. These are spleen, transverse colon, liver, diaphragm, pancreas, abdominal wall, adrenal gland, kidney, small intestine, and retroperitoneum. T4, further divided into T4A and T4B. T4A, tumor invades the serosa, visceral peritoneum. T4B, tumor invades the adjacent structures or the organs. Now, definition of the regional lymph node. There, if no lymph node is affected, then it is NX. And no regional lymph node metastasis is there, N0, and which cannot be assessed, is considered to be the NX. N1 is metastasis in one or two regional lymph nodes. Mostly important is the N3, where the metastasis in 7 or more regional lymph nodes are seen. It further divided into two groups, N3A and N3B, where metastasis in 7 to 15 regional lymph nodes considered to be N3A, N3B, where metastasis in 16 or more regional lymph nodes. And accordingly, there comes a distant metastasis, which is considered M0 and M1, according to their distant metastasis presence of their reads, present or absent accordingly. And clinically, it is further staged according to different T1, N0, and M0 status. This is a pictorial depiction of the AJCC classification, where it shows how far it has invaded into the stomach wall or surrounding. And another tool is Japanese Gastric Cancer Association staging system, which takes into account the hepatic metastasis stage, peritoneal metastasis stage, peritoneal cytology stage, along with tumor staging, nodal staging, and other distant metastasis staging. Thank you, sir.
Okay.
Thank you, Dr. Suman, for the wonderful presentation. Now, I would like to add only 2 points. One is you have mentioned in the familial and hereditary section, you didn't mention about the hereditary diffuse gastric carcinoma syndrome. Why I tell you why it is important. It is a autosomal dominant disease where CDH1 is at fault. This is the only scenario where a prophylactic gastrectomy is indicated. So a patient of CDH1 mutated patient who is suffering from hereditary gastric carcinoma syndrome, diffuse gastric carcinoma syndrome, in these patients at the age of 18 years to 40 years, prophylactic gastrectomy is indicated. So that is probably the only indication of prophylactic gastrectomy in a otherwise normal stomach. Okay, so that is one point. Another point is in AJCC 8 edition, there are few changes which are being added, like T4A and T4B. They have added. You have correctly mentioned. Now you tell me if a tumor in continuity involvement of greater omentum, whether it is T3 or T4, in continuity involvement of greater omentum, is it T4 or T3? So this part is very
These are in the box.
yes.
T3.
So, but the stomach is
T3.
covered by 2 layers of peritoneum. It goes and it covers the omentum also. So when you have incontinuity spread in the omentum, it is T3. But when there is a breach in the peritoneum, it is T4. Okay. This change is there, and they have now classified N3 into N3A and N3B based on 15 up to 15 and more than 16. So here why this nodal status is important. That means your minimum lymph node harvest in a gastrectomy specimen should be how much? 15 to 16.
15.
Isn't it? Because the N3B is more than 16 nodes. So in your specimen there should be at least 16 nodes. Okay, so that is one point. Can you tell me what is YTNM?
That is after pathological assessment.
Now, why?
Why YTNM? Why?
Now there is a regime of giving this patient
Sir,
some
after
Neoadjuvant
adjuvant
chemotherapy. After adjuvant chemotherapy.
new adjuvant.
Neoadjuvant.
So anything you are giving prior to your main treatment is neoadjuvant, okay? And your main treatment is going to be surgery. So you have given neoadjuvant chemotherapy in a patient and then you do surgery. So this after neoadjuvant chemotherapy, when you stage a patient, it's called YTNM, okay? That's fine. Okay.
And then in the group of protective elements for cancer stomach, I mentioned the diet, and aspirin is said to be a protective factor for gastric cancer. And in the same list, aspirin comes. And in the familial gastric cancer, what Dr. Somendas was mentioning, there is an association between the breast cancer. If you find in the family that one patient has got breast cancer and another has got gastric cancer, these are the other group of patients, and they are mostly associated with BRCA1 gene mutation. I think otherwise you have mentioned all the etiological factors, pathology, and different types. So extensive is not required, but at least you have gone through all the parts. So you can pass on to the next presentation.
Thank you, sir.
Yeah. Clinical presentation and diagnosis. Dr. Ganesh.
Good morning, sir. Good morning, everyone.
Yeah.
Carcinoma stomach, clinical features and investigations. The presentation of carcinoma stomach can be attributed to the pneumonic stomach itself. S for silent, most of the early gastric tumors are silent in presentation. They are asymptomatic. Tumor, that is mass abdomen. Most of the time when a patient is presenting as a mass abdomen, it is not the gastric mass. It is the metastatic mass in the lymph, in the liver nodes, which present as the mass. Obstruction, when tumor is in the pylorus, it presents as GOO, which is characterized by vomiting, which is non-bilious in nature. Melena, mild bleeding or oozing from the tumor surfaces, present as melena. Anemia is the most common symptom of adenocarcinoma of stomach compared to GIST, cachexia, hematemesis. Hematemesis is more common with GIST. By infiltration, tumor by spreading into the submucous and muscular layers leads to the loss of elasticity of the stomach, which in turn leads to loss of weight. Most of the time, patient complains of the pain of the abdomen, which is unrelated to food. Tumor, when infiltrated into the pancreas, may present as a back pain, which is like a epigastric pain, typically radiating to the back pain. By metastasis, Krukenberg tumors. Krukenberg tumors are bilateral enlarged ovarian nodes, occurs in the premenopausal woman. In premenopausal woman, the ovaries are active, the secret follicles, hence the raw surfaces are created. Tumor goes and deposits in the raw surfaces and forms the enlarged nodes, enlarged ovaries, that is Krukenberg tumors. Blumer-Schultz nodes, tumor deposits in the rectovesical pouch or pouch of Douglas is known as Blumer-Schultz nodes, which are palpated in perirectal. Sister Joseph nodules are the tumor deposits along the umbilicus. All the three are means of transcoelomic spread. By lymphatics, tumor cells by means of cisterna caelum travel through thoracic ducts and gets deposited in the supraclavicular nodes and the left axillary nodes, which are respectively called as Virchow and Irish nodes. Spread of the tumor by direct invasion into the esophagus, duodenum, rarely colon and pancreas. Lymphatic is to the 16th station of lymph nodes and through supraclavicular and Irish nodes. Transcoelomic spread is by Krukenberg, Blumer-Schultz, Sister Joseph nodules. Hematogenous spreads to lung and liver. Coming to the investigations, endoscopy helps in the visualization of gastric mucosa. In case of gastric adenocarcinoma, the mucosal abnormalities are more or less visible easily. But in case of GIST, it is not completely visible. And in lymphoma also, it is very difficult to find the mucosal abnormalities. In that cases, confocal, narrow band, magnification endoscopy are tried. Endoscopic biopsy. Endoscopic biopsy is the diagnostic procedure of choice. At least 6 to 8 endoscopic biopsies are required. The sensitivity of single biopsy is 70%, whereas the summon biopsy is 98%. The image you are seeing is the double bite forceps. By this, we can take 2 biopsies as a single time. The conventional endoscopy, you need to have 8 passes to take 8 biopsies. This double bite forceps helps in taking the biopsy at 4 passes. Endoscopic ultrasound. Endoscopic ultrasound tells about the depth of invasion, which is T-staging. It is around 90% sensitive. Locoregional disease, that is N-staging, it is 80% sensitive. In endoscopic ultrasound, the stomach wall is visualized in 5 layers. Out of this, layer 2 and 4 are hypoechoic, others are hyperechoic. Lymph nodes, which are usually metastatic lymph nodes, which are involved, usually present as like hypoechoic enlarged nodes. The sensitivity of depth of T and N staging sensitivity is comparatively better than a single T and N staging. Endoscopic ultrasound helps in differentiating the high risk versus low risk disease, which has a significant impact on the prognosis of the patient. Once the patient has been started with neoadjuvant therapy, then the endoscopic ultrasound will not be useful because the neoadjuvant will cause fibrosis of the muscular walls, and so that endoscopic ultrasound can't differentiate between. For early gastric cancers, which is like T1A, when that is less than 2 centimeter, where endoscopic mucosal resection is planned, endoscopic ultrasound is mandatory. CECT is the investigation of choice for staging. It tells about the adjacent organ and lymph node involvement. Tripasic CT of abdomen, chest, pelvis with oral contrast is now routinely used. In early gastric cancer, CECT is not that much sensitive as compared to the endoscopic ultrasound. As the stage of the cancer increases, the CECT is more accurate. T-stage sensitivity increases as the stage of the disease increases. Diagnostic laparoscopy. Occult metastasis less than 5 mm can be diagnosed by diagnostic laparoscopy. Diagnostic laparoscopy helps in the direct visualization of peritoneum and visceral structures. Diagnostic laparotomy, it has reduced the unnecessary laparotomy reduction by 30%. NCCN recommends like to do diagnostic laparoscopy for from stage 2A, that is T to N1. Disadvantage of doing diagnostic laparoscopy as a separate procedure is like cost and side effects of GA, whereas the advantage is after knowing the proper staging, the patient can be counseled properly and we can have an MDT approach. Diagnostic laparoscopy is planned only for patients with curative intent and it is not useful in planned palliative procedures. Laparoscopy is usually followed by peritoneal lavage, where the cytology of the peritoneal fluid is studied. And this has changed the treatment pattern around 6 to 60% of the patients. Laparoscopy ultrasound is more sensitive in detecting liver mets and visceral mets. FDG PET is only 50% of the gastric tumors are FDG PET positive. This is due to the absence of glutamate receptors in the gastric adenocarcinoma. FDG PET had reduced the unnecessary laparotomy by 10%. That is like if the initial staging of the patient is M0, after FDG PET, the stage has been converted into M1. So the treatment has been changed. NCCN recommends to do FDG PET for all M0 metastasis. Then there is no use of doing FDG PET in M1 cancer. FDG PET on day 1 and day 14 helps in assessing the response to neoadjuvant therapy. Those patients who are having a good response to the neoadjuvant in the 1 to 14 days have a better overall survival. Ultrasound as a clinical extension is a basic initial investigation. If ascites and large intraperitoneal nodes are detected in the ultrasound, then most of the diagnostic laparoscopy and FDG PET are not required. Barium is not now routinely done. In initial days, they used the barium studies. Malignant ulcer usually produce a Karaman-Minsky sign. In diffuse gastric cancer such as lentitis plastica, the stomach shows a contracted appearance. Tumor marker, there are a variety of tumor markers, CA-72-4, CA-19-19. Most of them are non-specific. They are elevated in both benign and malignant conditions. Out of this, CA-72-4 is most commonly studied. They correlate the severity of the disease. The greater the value of the tumor markers, greater severity is the stage of the disease. Tumor marker also tells about the burden and biological type of the disease. Screening is done only in endemic zones like Japan and in high-risk areas where the number of prevalence of the disease is greater than 20 per million. Screening usually involves reduction of H. pylori, serum pepsinogen, and the ratio between the serum pepsinogen 1 and 2. Endoscopy as a screening is not cost-effective. Ertunew screening is done only in the metastatic cases where if the tumor is responding to Herceptin, then they have a good prognosis compared to the other patients. Thank you.
Okay, Dr. Ganesh, that was a crisp presentation. Few points regarding endoscopy. You have mentioned that you are seeing the tumor. You are seeing the. Go back to the endoscopy slide. Yes. So 6 to 8 biopsies are mandatory. So what do you look at when you are doing a endoscopy and seeing the gastroesophageal junction? Do you have any classification out of that? Because all G junction cancers are not neither esophageal nor gastric cancers. There is a classification called Seward classification. Okay, so Seward classification is based on the epicenter of the tumor. If it is located 1 centimeter to 5 centimeter above the gastroesophageal junction, it is Seward 1. Seward 2 is 1 centimeter above to 2 centimeter below. Okay, and Seward 3 is 2 centimeter to 5 centimeter below. Out of these, Seward 1 and 2 are taken as esophageal cancers, where this type 3 is taken as gastric cancers. So this Seward type 3, you have when you are doing an endoscopy and you are seeing a G junction growth or a growth in the upper part of the stomach, mention that whether it is a Seward 1, 2 or 3. Okay, because the whole management is going to change. That is one point. Next point is, when do you do endoscopic ultrasound? Endoscopic ultrasound.
Sir, when the unable to visualize the mucosa properly, that is the time when endoscopic ultrasound uses.
Yes, so that is one in case of G-stan, etc. For a diagnosed gastric cancer, if it is a very early cancer like T1A or T1B, you want to differentiate, there endoscopic ultrasound is very important. Another is when you want to differentiate between a T3 lesion and a T4 lesion. So this is quite advanced. So yeah, we used to think that endoscopic ultrasound is always applicable for very early gastric cancers. So endoscopic ultrasound is a very important or a very useful modality to differentiate between T3 and T4 because your management will differ in T3 and T4. Okay, and it's a very good investigation to see localized lymph nodes. Okay, and the left lobe of liver is very well seen by endoscopic. Okay, and you have mentioned that diagnostic laparoscopy, it is stage 2 onwards, you said?
Sir, from T2N1 stage 2A.
So this has been revised. Right now, the recommendation of diagnostic laparoscopy is almost in all cases except T1A lesion. Okay.
Yeah.
So any lesion more than T1A will require a diagnostic laparoscopy. If you are planning for either direct surgery or a neoadjuvant chemotherapy, so if you are planning a neoadjuvant chemotherapy, you put the patient, do a diagnostic laparoscopy. Document that it is not a metastatic disease. And remember, this peritoneal washing with 200 ml of saline is mandatory in diagnostic laparoscopy. So if this cytology is positive, then it becomes an M1 disease. Okay, so you don't treat as a curative with a curative intent in those patients. So diagnostic laparoscopy is almost mandatory for now. NCCN is recommending any lesion more than T1A will have a diagnostic laparoscopy. Okay, so I think that is okay.
Yeah.
And
in the presentation, in presentation, there is another broad group of patients who are presenting with advanced disease, like patient presenting with ascites, patient presenting with multiple liver secondaries with lumps in the abdomen, or this you mentioned about the distant nodes. So this is another group of patients who present with advanced disease at presentation, because in those cases, clinically you can decide that these are the patients for only palliative care. Okay, and then you have not mentioned about dysphagia. You mentioned the outer obstruction. In the obstruction, dysphagia also comes in the tumor near the cardia.
Okay.
Otherwise, the presentation is of different groups. I like still the Belly Labs grouping of presentation. This is 3A, vague symptoms, obstruction, lump. You said lump is not always the metastatic part. In a proliferative growth in the stomach, sometimes that lump may also be palpable. It's not only the metastatic mass.
and a feeling of a rolling mass that also happens.
Yeah. The
Okay.
distended stomach, yes.
Yes, of dyspnea down.
Uh,
One just one more. Yeah. When do you don't do a PET scan or a CT scan?
Sir, when we know that it is clinically a metastatic disease or the initial ultrasound tells there is peritoneal large lymph nodes in this one, why we should
Right.
ascites.
So when you are doing endoscopy, you are sending the sample for biopsy. When do you do a HER2/neu assessment and a PDL1 assessment from this specimen?
Sir, when we know that it's a metastatic carcinoma, some of the metastatic carcinoma respond well to Herceptin therapy. Only in those cases we do HER2/neu testings.
Yes, there are three indications: metastatic setting, recurrent setting, and locally advanced irresectable setting. These three settings, you do a HER2/neu assessment because a large chunk of stomach cancer is now HER2/neu positive, and you have an option of giving trastuzumab to them.
Yeah.
And PDL1 also. PDL1 is recommended in metastatic setting. PDL1 is a modulator, immunomodulator. Pembrolizumab is available. Okay. Okay. So I think we can
Yeah.
move to the next presentation.
Next. Next is
Thank you, sir.
presented by Dr. Ishita Laha. She's a resident at RKM Share Pratishthan. So it will be on management, which will be covering both the palliative and definitive management. Dr. Ishita, please.
Yes, sir. Sir, am I audible?
Yes, you are audible and visible also. Start.
Okay, okay. Good morning, sir. Good morning, everyone present here. My presentation is on management of carcinoma stomach. The gastric malignancy, as my fellow colleague has already said, that it's the fifth most common malignancy worldwide and the third leading cause of cancer death. And its treatment demands a multidisciplinary collaboration between a medical, radiological, and surgical oncologists. And sir has also mentioned as the tumors, according to the ADCC 8th edition, the gastroesophageal junction tumors with the epicenter of the tumor is less than 2 centimeter in the proximal stomach are staged as gastric cancer and tumor. With tumor of the with epicenter of the tumor more than 2 centimeter into the proximal stomach are staged as gastric cancer, and tumors at the gastroesophageal junction with the epicenter of the tumor less than 2 centimeter into the proximal stomach are staged as esophageal cancer. And the TNM classification has already been described by my colleague. I just want to mention here one single thing: the distal extension of the tumor in the duodenum does not alter the T stage. The ADCC staging guidelines suggest that at least 16 lymph nodes needs to be harvested while dissection of the specimen, and microscopically positive peritoneal cytology in addition to frankly macroscopic peritoneal disease is considered M1. Also, metastasis to non-regional lymph nodes like the para-aortic and the retroperitoneal on the mesenteric lymph nodes are considered M1. The aim of operative treatment is always a R0 resection, and the type of surgery which we want to perform is always depends on the tumor growth, the growth pattern, and the tumor location. Endoscopic mucosal resection is an endoscopic approach for a very early cancer like T1A lesion, and the absolute indications of EMR is a well-differentiated tumor less than 2 centimeter in diameter confined to the mucosa without ulceration. The indications can be expanded as well. It can also be applied to well-differentiated non-ulcerated lesions with more than 2 centimeter, as well as very well-differentiated less than 2 centimeter ulcerated lesions as well. And it's an option for the treatment of very early stage gastric cancer, but appropriate endoscopic expertise and commitment to long-term follow-up are necessary if we are planning for endoscopic mucosal resection. The proximal margins, as suggested in the gastrectomy, macroscopically, macroscopically as classified in four types, mass and ulcerative type. For that, proximal margins, according to the recent guidelines, are kept to be as 3 centimeter, whereas in infiltrating ulcerative or diffusely ulcerative type of gastric adenosia, a proximal margin of 5 centimeter is adequate. Then how much stomach needs to be resected, that depends on where the tumor position is and what type of tumor. In subtotal distal gastrectomy, we generally prefer with antral and body tumors, whereas we prefer total gastrectomy in upper body or fundal tumors, or in any location of the tumor with pancreatic invasion and that requires splenectomy, and the greater curvature tumor with enlarged 4SB nodes, that is which are involving the splenic hilum. Lymphadenectomy, as my fellow has already said, that there are 3 echelons, and we usually go for first and second echelon dissection, and that is denotes by D2. And according to the Dutch trial, a statistically significant difference in overall survival favoring D2 has already been studied. So we, in any case of gastric adenosia, we prefer R0 resection with D2 lymphadenectomy. These are the various lymph node stations. Locally advanced tumors are T4B lesions, and resection of the involved organs has also been done, or in an effort to achieve R0 margins is acceptable if the patient is physically fit to tolerate such extensive operation with no evidence of metastatic disease. And spleen should be preserved unless directly involved. And as this has been the evidence from various studies. Laparoscopic resection is also done. Class 1 trial examining the laparoscopic versus open distal gastrectomy with D2 lymphadenectomy for patients with advanced gastric adenosia report no difference in perioperative morbidity and mortality. The complications apart from the large and extensive operation like gastrectomy, or subtotal gastrectomy. Apart from routine complications like pulmonary issues and bleeding, infection, cardiac issues, and venous thromboembolism, our concern major is of anastomotic leak and dumping syndrome. Now, approach to anastomotic leak, we mainly try to manage it conservatively with adequate drainage using percutaneous drains. If not, drains are placed in the first setting, or endoscopic stenting and nutritional support with jejunostomy feeding. Oral feeding typically starts between POD 4 and 7, though we supplement the jejunal feeding right from POD 1 until adequate oral feeding is achieved. 10% patient develops dumping syndrome. Early dumping syndrome develops between 15 to 30 minutes post-meal, which includes symptoms like diaphoresis, severe abdominal crampy pain, palpitations, and watery diarrhea. And late dumping syndrome generally develops 2 hours post-meal, which is mainly due to hypoglycemia and hyperinsulinemia. The medical management includes dietary modifications like increased high fiber diet with avoidance of concentrated sweets and avoidance of hyperosmolar liquids, and short frequent meals. The survival from a gastric adeno-CA, which depends on the locoregional recurrence rates. Locoregional recurrence rates after R0 resection remains very, very high. The most common recurrence sites after potentially curative gastrectomy are peritoneal, followed by locoregional and liver metastasis. Most recurrences occur within 2 years after resection, though the median survival after recurrence is 6 months. Perioperative chemotherapy. Nowadays, we follow the FLOT regimen, which has been found to be superior than MAGIC. FLOT regimen consists of 5-fluorouracil, leucovorin, oxaliplatin, and docetaxel. In patients with adequate D2 lymphadenopathy, there is no additional benefit from adjuvant radiotherapy as proved in the ARTIST trial. Now, metastatic disease. About 40% of patients will present with metastatic disease at the time of presentation, and palliative measures are initiated not only to increase the duration of the remaining life, but to improve the quality of life as well, and can be given through systemic chemotherapy. Palliation with endoscopic techniques may be appropriate for patients with peritoneal disease, hepatic metastasis, extensive nodal metastasis, or ascites, and for patients with problems that include bleeding or gastric obstruction. Laparoscopic HIPEC may be considered to palliate debilitating malignant ascites, which is a new treatment in the setting. And then after the resection, we follow it up. We follow it up every 3 months for first 2 years with clinical history and examination, and with laboratory with labs like CBC, LFT, albumin status, and vitamin D, iron status. Every 6 months for first 2 years with CT, chest, abdomen, and pelvis, and followed by yearly thereafter. And once yearly upper GI endoscopy for the first 2 years, followed by once again after 5 years. And lastly, I would like to summarize by saying that if we find a patient of gastric adeno-CA, we first go for endoscopic upper GI endoscopy, followed by staging, and then followed by staging laparoscopy. According to the stage, we either give or not give perioperative chemotherapy as per FLOT, and then we go for restaging. Then we go for gastrectomy, subtotal distal gastrectomy with D2 lymphadenectomy, followed by again 4 cycles of FLOT, and there is no need for adjuvant radiotherapy. Thank you, sir.
I think you would have touched a little about the adjuvant therapy in the post-op setting. Okay, chalo, ठीक है, we have a discussion.
Okay, so let us come with the metastatic part first. You told that endoscopic stenting is a good option for gastric outlet obstruction. So when do you do a surgical gastrojejunostomy, and when you prefer to do an endoscopic stenting in a metastatic gastric outlet obstruction patient?
Sir, in metastatic gastric outlet obstruction, where patient is not able to withstand any long
both can withstand 2 to 3 hours surgery.
Sir, in that case, depends on the expertise and the availability of instruments at the institution which we are likely to. And also the high volume in high volume centers, we can go for gastrectomy, where post-operative management is can be managed well.
So the issue is palliative gastrectomy is indicated for bleeding, a bleeding situation where you are having a tumor which is bleeding like anything, and you are not able to control it by endoscopic manner or by giving a palliative radiation. So that is a situation where you will go for a palliative gastrectomy. What I'd like to say that a patient with gastric outlet obstruction, if you are seeing this patient is having a survival of more than anticipated survival of more than 6 months, then it is a surgical gastrogenectomy which is done. But if a patient where you are expecting this patient is going to die in another 2 to 3 months,
Very advanced disease.
doing a surgical bypass in this patient. Okay, so that's the idea behind a surgical bypass and a endoscopic bypass. And regarding the lymph node dissection, so can you define a D2 lymph node dissection?
So D2 lymph node dissection involves the first and second echelon group of lymph nodes, and first echelon involves the perigastric lymph nodes like the right cardia, left cardia, lesser curvature, greater curvature. But greater curvature bearing the 4 SB lymph nodes, that is nearing the splenic hilum, and the suprapyloric and infrapyloric.
When do you dissect a splenic hilar lymph node, and when do you do splenectomy?
Sir, we do dissect splenic hilar lymph nodes if they are small, but if they are large group of lymph nodes severely adhered to spleen, and when we have to go for total gastrectomy, we go for splenectomy as well.
Yes, that was the initial concept, but right now splenectomy is only necessary in and when there is a direct involvement of the spleen from a greater curvature lesion, high up lesion, directly invading the spleen, and there is no other metastasis. Okay, here you do a splenectomy or heavily studded hilar lymph node. Okay, where dissecting these lymph nodes will
cause torrential bleeding.
yes, will warrant a splenectomy. Okay, these are the two situations. Okay, you tell us something more about pre-operative chemotherapy. When do you give pre-operative chemotherapy?
Sir, in locally advanced disease, pardon, sir?
What was there in MAGIC trial and what is there in FLOT trial?
Sir, FLOT trial involves 5-fluorouracil, leucovorin, oxaliplatin, and docetaxel, whereas in MAGIC trial we have the we don't have docetaxel, we have capecitabine and oxaliplatin.
Okay, so I'll tell you.
And 5-fluorouracil also.
Yes, ECF regime. PUBC, and so MAGIC trial initially showed us that in a resectable gastric cancer, find it, in a resectable gastric cancer, if you give pre-operative chemotherapy, then there is an overall survival benefit.
Yes.
Clear? And that is to the tune of 30 to 40% compared to patients who are undergoing surgery only, followed by adjuvant therapy without any pre-operative chemotherapy.
Yes, sir. One more thing. Classic trial was for adjuvant and MAGIC.
So this MAGIC trial showed us that if you administer chemotherapy in neoadjuvant setting in resectable gastric cancers,
yes.
So it is not for unresectable one, it is for resectable gastric cancer. When we call unresectable, when the mesocolon is involved, that is the mesentery, root of mesentery is involved. When you have
aortic lymph nodes are involved.
When you have an peritoneal disease, and when you have an unresectable in continuity metastasis. Suppose the
এটা কেটে নেওয়াই ভালো। হ্যাঁ স্যার সেটাই রুটিন ইনভেস্টিগেশন গুলো করে চলে।
Oh, acha. Okay. Okay, so these are three situations when you find it irresectable. So MAGIC trial was for resectable gastric cancer. So that there is a overall survival benefit. Now FLOT is a different regime of chemotherapy. So the difference between MAGIC regime and FLOT regime, that was the ECF regime. This is a FLOT regime. Okay, so you give 4 cycles of FLOT followed by surgery, then 4 cycles of FLOT. So they have compared MAGIC with FLOT. Okay, so ECF regime with FLOT. They have shown the FLOT is more beneficial in comparison to MAGIC trial. So right now, the standard of treatment for resectable gastric cancer, okay, is to give FLOT if the patient is fit, because FLOT is a toxic chemotherapy. So patient needs to be fit for that. Okay, And what are the indications of pre-operative chemo radiation and post-operative radiation?
Sir,
Mentioned that post-operative radiation is not recommended if you have done a D2 gastrectomy. So that is a result of artist trial, you said.
yes, sir.
So you have
Sir,
corrected that. So what are the indications of post-op radiotherapy? You have operated in a gastric cancer patient, and what are the indications where a radiation oncologist will give radiotherapy to a patient?
Sir, in case we have node positive, margins positive but node negative, sir. Margins positive and node negative disease, we give radiotherapy to the gastric bed, and also for
So
metastasis to other organs,
no,
bones.
these are all resectable, locally advanced disease. So you have done a gastrectomy, you have done D2 dissection. So there, whatever the node positive is, if you have done a D2 dissection, radiotherapy is not indicated. Clear? If you have done anything below D2, that means suboptimal lymph node dissection, there your radiotherapy is indicated. Where you have a R1 disease, so macroscopically negative but microscopically positive, that is R1 disease. So if you have an R1 disease and you don't have the scope of doing a revision surgery, their radiation, post-op radiation is clear. And pre-operative radiation, right till date, pre-operative radiation is not having any established data. There is a study called Top Gear study that has completed their recruitment in 2020. That is looking into the fact that all resectable gastric cancers are divided into three arms. One is undergoing chemotherapy, followed by surgery, again chemotherapy. That is a FLOT regime. Another group, chemotherapy, concurrent chemoradiation, surgery, then adjuvant chemotherapy. Another group, chemotherapy, sequential, chemotherapy followed by
Chemoradiation.
then surgery, then the results are awaited. Okay. So till date, preoperative radiation is not indicated. If it is unresectable one, then chemoradiation remains the treatment of choice. So if we summarize the whole thing, it is how do you divide gastric cancers? One is metastatic disease, one is
Early gastric and locally advanced.
in early gastric cancer, you have T1A and T1B. T1A disease, you go for endoscopic resections. Okay.
Yes, sir.
For T1B disease, you go for radical gastrectomy. So that is the only area, T1B, where you can go for gastrectomy directly and giving pre-operative chemotherapy is almost similar in T1B lesion. Okay. Now for locally advanced, that is anything more than T1B, they are divided into two groups. One is a medically fit and medically unfit. So if it is a medically fit group, you go for pre-operative FLOT. Okay, FLOT surgery followed by FLOT. So that's the more or less treatment dictum for carcinoma stomach. Okay, so that was wonderful presentation from your part.
And another thing is, while you're doing gastrectomy, most of the time we add a feeding jejunostomy.
Yes, sir. I forgot to mention that.
Post-op.
While doing staging laparoscopy only, most of the time we go for feeding jejunostomy at the same setting.
No, staging laparoscopy, if you're not resecting and the patient is not outward obstruction, there's no need for doing a feeding jejunostomy.
Yes.
If the patient has got an obstruction, you do a FJ and then continue.
Sir, but nutrition is generally poor in gastric carcinoma patients. So sometimes we
if the
prefer
patient does
doing.
not have outward obstruction, then don't add a FJ. And secondly, regarding the margin you're talking, you said that the proximal spread is up to 5 centimeter and the line of resection is usually 6 centimeter. I don't find you say 3 centimeter the proximal margin of resection.
Sir,
say 3 centimeter.
sir, yes, sir. If there is a mass and ulcerative lesions, as we see in the macroscopic histological classification, so the proximal margin is said to be kept as 3 centimeter, and if there is a diffusely ulcerative and infiltrating ulcerative lesions, proximal margin at 5 centimeter.
Most of the description, Dr. Soman, what do you feel?
Yes, it's 5 centimeter plus 1, that is 6 centimeter.
Okay, okay, sir.
Sir, may I interrupt?
Yes, sure.
Sir, in the Japanese guidelines, they have said that if it is a well-differentiated tumor, then a 3 centimeter margin is added. That is the Japanese guideline.
Okay, Saurabh, any other comment?
Sir, very briefly then, in the first presentation, maybe just a little more focus on the molecular classification. He has presented a slide for molecular classification, but I would just bring out that now it is coming more into prominence. So there are 4 types: the mesenchymal type, the microsatellite unstable type, the TP53 active type, and the TP53 inactive type. The mesenchymal type is the most common presentation, around 30%. All others are between 22 to 24%. The mesenchymal type is associated with the worst prognosis. The microsatellite unstable type is associated with the best prognosis. The mesenchymal type generally occurs at an earlier age and more correlation with the diffuse type, the hereditary diffuse type of gastric cancer. In the second presentation, maybe I thought he could have added a little more about endoscopic narrowband imaging and chromoendoscopy. He mentioned it again in passing, but he did not mention the details, like what are the dyes used, what actually happens. So in case of stomach, endoscopic of the stomach, they generally use a methylene blue for early. These are important not in our country because we get advanced tumors, but in countries where the tumors are not so advanced or there is a screening program, you might get very small lesions which are not so very prominent and you don't know where to take the biopsy from. Then use of a dye called methylene blue, which colors up the intestinal metaplasia areas. So you know that from the Lawrence classification that CS stomach has got intestinal type and a diffuse type. So the intestinal type may not be so well prominent in the early stage. Use of dyes like methylene blue or phenol red will help in differentiating the area which is abnormal in the mucosa and direct your biopsy from that. And before doing that, you sometimes use acetylcysteine to clear off the mucus, and you also use a secretagogue and you use a antiperistaltic agent to relax the stomach. So as a postgraduate, maybe they can mention a little more about in detail. Similarly with narrowband imaging. Narrowband imaging, they use a specific wavelength of light which allows them to penetrate the mucosa and go into the submucosa to visualize the abnormal vascular branching patterns. And that again helps you to identify some areas of dysplasia or early cancer where you can direct your biopsy. And in the third presentation, I think I would just say that maybe a little more discussion about D1 versus D2, the evidence behind D2 and why we recommend D2, and some methods about reconstruction, like what are the options after a total gastrectomy, whether to do a pouch or not, whether to put in a drain or not at the end of the procedure. We have randomized evidence for all of that, whether to routinely use a nasogastric tube or not. These are surgical issues, which I think should be highlighted. Integrated multimodality management is of course important, and they have mentioned that very well, summarized it well. But maybe a little more discussion about surgical issues like a double track reconstruction, use of a Hunt-Lawrence pouch, whether to use a pouch or just do a esophagojejunostomy after a total gastrectomy. These things. Other than that, very nice.
Billroth 1, 2.
Yeah, well, exactly. Whether to go for a Billroth 1, whether to go for a Billroth 2.
And so, Saurabh, what do you feel in a patient who is having early age of presentation? Should the genetic testing be mandatory?
Sir, we don't have evidence for that because the genetic testing for that person alone may not make too much of a difference. That person is going to get treatment. He has presented.
No, I felt for the
about the relatives. Relatives. So there are lots of ethical issues, even in a place where, like breast, where there is a very strong role of genetic testing. Even there, they say that you need to discuss the implication. So suppose you do the testing of the relative and it comes out to be CDH1 positive, and then you recommend a total gastrectomy. Are we sure that a patient with a CDH1 positive is 100% going to get a cancer? No, we are not sure. Are we sure that if we do a total gastrectomy, the patient is going to have 100% survival? Can we guarantee? Can any surgeon guarantee that after a total gastrectomy, the patient will not die? So maybe the patient would never have got a cancer, but we advise surgery and the patient dies as a complication of surgery. So these are things that we have to discuss with the patient. So the patient was happy, the relative, this is not a patient, this is the relative of the patient. He was happy. We advised him to get the genetic testing done. Now he is CDH1 positive. Now he is anxious. He is worried whether he will get a cancer or not. We don't have an answer to that. We don't have a 100% sure foolproof method of cure to offer. So should we offer genetic testing in that situation? We are already overburdened. Our healthcare system cannot give adequate optimal treatment to whatever cancers we have already got.
Yes.
So should we go looking for more?
Yeah. And
So
second
these are ethical issues.
yeah. And second is not gold standard to have prophylactic
It's not a
aspirin in
gold
all
standard.
patients.
No.
So the option is either you, but the point is, if you have a high risk group being identified, you can follow them up very
With
closely.
screening, yes.
In that case, that if you detect it early at least.
Yes, that is a fair point. That is a fair point. So you can discuss that option. If they are willing for early screening, maybe you can go for intensive surveillance, repeated endoscopies and all.
Yeah.
That might help.
Dr. Maiti, any comment?
Excellent seminar, and the presentation by the students was very good, and the discussion by you and Dr. Somen and Saurabh was very interesting, and many things I have learned too. And one query from Dr. Saurabh: how many prophylactic gastrectomy is been done throughout the world till now? Any record?
Sir, I don't have data for that, sir. I don't think it's done in India. That is all I can say.
Is it really done or just
Yes,
a proposition?
it is done.
I think Showman will be the better person to answer that because he brought up that point.
Okay. Another thing is that in the presentation, clinical presentation, the student has mentioned about the varicose lymph node, but the iris node that should also be told in the presentation because iris node in the
He mentioned iris.
He mentioned this.
Okay, mentioned. Oh, sorry. And regarding the common presentation, that the term 3 A's in the clinical features: anorexia, asthenia, and the anemia. This is a popular dictum slogan for the detection of early gastric malignancy. If that is mentioned, that could be good. And regarding the biopsy, endoscopic biopsy, nicely discussed, but the well biopsy, which was discussed in the previous class, that should also be mentioned here, because the diagnosis of diffuse type of gastric malignancy is very difficult if the endoscopic biopsy is superficial one. In that case, the biopsy from the deeper plane in the form of well biopsy may be helpful. These are the things I like to comment. It was very wonderful discussion and the presentation by the students. Thank you.
Dr. Moshak, Dr. S.N. Moshak, any comment? We have time, 5 minutes. Dr. Moshak.
And Dr. Somen, what is your comment regarding the positive report in case of peritoneal lavage in diffuse peritoneal metastasis? In what percentage of cases the result become positive in the lavage? False negative rate, how much it is?
No, false no. If you have a obvious peritoneal deposits, don't do lavage. If you can visualize there is peritoneal nodules, then lavage is not required. Lavage is done when you have no demonstrable disseminated disease. So we find, we have done a study thesis about 3 years back. It's about 20 to 30% patient is upstaged to a stage 4 disease with lavage. There is 20 to 30% chance that early mimicking cancers are having a positive peritoneal cytology.
That is a very good study and good observation.
As a whole, this diagnostic laparoscopy as a whole, the till date data is it will upstage the disease to 31% cases.
Yeah.
That is the NCCN data.
Dr. Acharji, any comment?
Excellent, crisp and precise presentation by the students. And we, at least myself, was actually enriched by inputs from Dr. Somen and Dr. Saurabh. Thank you, Somen and Saurabh. Very good. And Dr. Shaha,
Yes.
I think you started your first study when I was also in PG. That was before 2012. And later,
but we did a thesis afterwards.
Afterwards you did a thesis, yeah.
There was 50 cases and that is well published.
Yeah. Thank you.
Thank you. So from June we'll have a new class schedule. Yes.
Another question, I have a query. Dr. Somen, you just discussed when you will not plan the gastrojejunostomy. Is there any indication if the tumor is extending up to the body or the lower two-thirds of the lower two-thirds of the body of the stomach? Will we go for gastrojejunostomy or will go for other option?
Yes. So for a tumor which is located proximally near G junction of the cardia, going to develop less often that it will develop gastric outlet obstruction because of the location itself. So mostly the distal tumors, antral tumors, and the body tumors which are near the lesser curvature, they will develop the gastric outlet obstruction more. So when you have a patient with gastric outlet obstruction and primarily the disease is unresectable or metastatic, then it will depend on the survival expectancy of this patient. If the survival expectancy, say for example, there's a limited disease near we have para-out node. So that is really acceptable. And patient is not bleeding, having gastric outlet obstruction. So here gastric is not coming into better in comparison to endoscopic.
Thank you. Thank you.
Okay. Any comment from the other students? Any question? Okay then. We close. Saturday we'll have a journal club presentation. Last program for the month. Okay. Thank you.
Thank you, sir.
Thank you. Thank you, Shoman, for a very
Thank
good
you, sir.
discussion. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.